people who are pursuing their career in the medical field to take up innovative stuff and do something great as you have done in your career. Thank you so much, sir, for joining us.
Thank you.
Sir, you have been practicing gastrointestinal and HPV surgery for many years. What initially attracted you to this specialty, and how was your understanding of good surgical care had changed over time?
Okay. So, to answer the first question, my father is a surgeon. He had done his FRCS from abroad and he had come back to settle in my hometown, that's Palakkad in Kerala. So, that was definitely one major inspiration. The second inspiration came actually from one of the surgeons who actually operated on my uncle. My uncle was diagnosed, unfortunately, to have colorectal cancer when I was maybe in, say, immediately after my 12th standard. So I was there with him to take care of him and look after his needs during his hospital stay. And then what happened was that I used to see this portly surgeon coming every day on the rounds and, taking good care of my uncle. So I was also drawn towards that. And I decided that, I will definitely become a surgeon who is going to operate on cancers. Therein started my journey.
Yes.
So I had decided that, I will become a surgeon and I will operate on cancers so that, I can help patients get rid of them. So therein started my journey as far as gastrointestinal surgery is concerned. Now, to answer your second question, could you repeat that question again, if you don't mind?
Yes, sir. How has your understanding of good surgical care changed over time?
Okay. So when I was doing my general surgery residency, my senior who was there, he told me that gastrointestinal surgery is nothing but very refined general surgery. Those words still echo in my mind. So basically, what he wanted to convey and what I understood was that gastrointestinal surgery represents the best, the essence of what a good general surgical practice means. Except for the fact that, we focus only on the abdominal viscera and we don't generally operate on structures which are outside the abdominal cavity. So, I have seen the whole gamut of procedures ranging from how gastrointestinal surgery was when I started my residency in GI surgery in All India Institute in 2005 in July to, how it
I think, sir, there's some incoming call coming up, I think.
yeah. So can I? Unfortunately, there's no way I can. So when I was doing my general surgery residency, I was told that GI surgery is nothing but refined general surgery. And then those words still echo in my mind. I have seen how GI surgery actually evolved from the time I did my GI surgery residency in 2005. At All India Institute of Medical Sciences, where we focused on more of core gastrointestinal surgery, which was more of focused on open GI surgical procedures. And then by the time the laparoscopic revolution was taking place in India, and then most of the gastrointestinal surgical procedures which we used to do by open method got done by the laparoscopic method. And then you had this wave of robos coming in. Initially, it started off with the Da Vinci robo by the Intuitive Surgicals. And then now that the patent for the robo has actually expired, you have a lot of Chinese robos and even homemade Indian robos like SSI Mantra coming up. And then most of the procedures being done by robotic route. And then, when I was a resident, I read about the first transatlantic tele-robotic surgery taking place between France and Strasbourg and New York, wherein a surgeon who is sitting in Strasbourg could operate on a patient who is in New York by means of high bandwidth internet and robotic surgery. Now the same thing is being practiced or being done left, right, and center in India. I see surgeons boasting of robotic telesurgery, wherein they are sitting in Bangalore on a console and they are operating on a patient in Delhi. So we have seen this evolution of gastrointestinal surgery happening from open to laparoscopic, laparoscopic to robotic, robotic to robotic telesurgery, and we don't know what the future holds for us.
Right. Sir, just a side question is that, these days, especially after COVID, a lot of stress related diseases have actually developed. And that is where I see a lot of people, suffering from gastrointestinal, diseases have taken a bump. Um, do you, sir, so I'd like you to explain that, how stress affects that, how stress leads to bloating, gastrointestinal diseases.
That's a very good question. See, you know what? COVID has been a big spoiler in more ways than one. COVID has actually spoiled the careers of a lot of people. COVID has actually spoiled the health of a lot of people. COVID has scalped a lot of lives. And especially of those who are elderly and those who have had a lot of comorbid conditions and who are unfortunate to have been afflicted with COVID. As far as the stress aspect of COVID is concerned, the very fact that they were afflicted with COVID, during that period of 2020 to 2022, when we knew very little about this virus, except for the fact that it originated from China, got imported all over, to India, by passengers who were traveling from China, Wuhan. And then, you had everybody, walking around with COVID. So that itself was enough to send not only the media, but also the individuals into a frenzy. And the very fact that there was no vaccine available at that point of time, the very fact that there was no remedy available at that point of time, all added to the stress. Along with that, a lot of cocktail therapies on WhatsApp saying that, this could work. You take ginger, amla, lemon, and that will work. To drugs, which are never tried before, saying that that would work. So, there was so much of misinformation. So people really were clueless, and all that actually added to the stress. Now, apart from that, the virus per se caused an inflammation inside the body. It also produced what is known as a microvascular thrombosis, which means that because of the low grade inflammation, it used to affect the small blood vessels and it used to produce blocks in those blood vessels, known as microvascular thrombi. Now, this was the one which actually led to a lot of complications. Now, the problem doesn't end there. People who were afflicted with COVID and who had stress, they actually went on to develop, a lot of them went on, if they were, healthy enough to survive the illness, they went on to develop a lot of illnesses like diabetes, for which, stress plays a big role. And the trigger for diabetes in those patients was the COVID virus itself. Secondly, a lot of patients who had these sort of microvascular thrombosis, and if they were unfortunate enough to have comorbid illnesses like chronic renal failure and cardiac disease, they usually succumb to it, unfortunately, because that virus-induced inflammation was enough to produce a block in the blood vessels which supply the heart or the kidneys, and either they developed heart attacks or their kidney failure accelerated, and unfortunately, they lost their lives. Now, if they were lucky enough to survive that, like, a lot of people, you would be seeing in the society who had COVID, but they survived. Many of them still are carrying the stigmata or scars of the disease or the residual sequelae, as you would say, in form of diabetes or, various other comorbid conditions. Now, to answer your specific question on stress and gastrointestinal disorders, stress plays a very intimate role as far as gastrointestinal disorders are concerned. Stress is known to not only be the inciting factor, it is also known to be the aggravating or the precipitating factor. When I say incite, it actually kicks off or starts the disease. When I say it's the precipitating or the aggravating factor, it even worsens the disease which has already existed inside the body. So in both ways, stress is a spoiler. Now, what are the specific diseases which I am talking about? The key diseases are: one is inflammatory bowel disease, ulcerative colitis, Crohn's disease, indeterminate colitis. Point number one. Point number two, irritable bowel syndrome. Yes. IBS, very common in the society. You'll see people saying that, oh, I got a bad tummy, oh, it's IBS. And, you'll see people roaming around saying that. Third one, patients who had peptic ulcer disease, for which, stress is a major trigger factor. So the list is endless. Even diseases like pancreatitis, can all be aggravated by stress. So stress can be a major factor for a lot of gastrointestinal illnesses with really bad results. So it's very important that stress is kept under control in order to achieve optimal results as far as management of gastrointestinal diseases are concerned.
Right, sir. And do you also think that the proliferation of these social media sites and a lot of time being spent on mobile phones and all has also contributed to a stress in the form of FOMO that's being created?
Yeah, so FOMO, the fear of missing out, is, I think, what you are referring to. Now, FOMO has been there for everything. The first time I got introduced to the word FOMO was in the stock market, because there's a frenzy which is whipped up saying that, some stock is going up. And so if you don't latch onto it, you're not going to make money. And so everybody goes behind the stock and suddenly it comes tumbling down and you all lose the money. Now, the same thing exists almost everywhere. FOMO has been there everywhere. Misinformation which is being spread on WhatsApp or any other form of social media, could even be through influencers on Instagram, Facebook, you name it, any of the social media for that matter, has been really, really bad. Why it has been really bad? Because, as I told you, I had at least some 5 or 10 patients during the period of COVID when, I was one of those very few medical practitioners who were actually practicing medicine during the time of COVID. Because many of the people would shun, saying that, they don't want to see patients because they don't want to get exposed to a potential COVID a carrier. So I had patients coming and sitting in my OPD saying that, oh, look, we are having severe heartburn and all that stuff. They used to rub their chest and show me. Now I used to take a detailed history and find out as to why, what exactly led to it in the first place. And then they would say, we took this cocktail of ginger, turmeric, amla, honey, lime and vinegar, and you name it, and we read it somewhere on WhatsApp that this kills COVID viruses, so we were gulping it twice a day, morning and evening. So that is the power of social media. Normal individuals can actually be made into patients just by spreading misinformation, like how we saw social media can trigger revolutions, as it happened in Egypt, Tunisia, and a lot of other countries. In the same way, social media can actually render a whole lot of population extremely susceptible to misinformation campaigns leading to disastrous consequences. So, heartburn might be the least of the health concerns which social media would have actually created through disinformation. I've had patients, who had even developed liver cirrhosis because somebody said that, you take herbal medicines and, you'll get cured of liver disease even if you drink alcohol. So, they keep on drinking alcohol and they pop, herbal medications thinking. Now, both alcohol and the herbal medications kick the liver, and they don't know that. And then they ultimately land up in a hepatologist clinic with liver cirrhosis. So you name it, it's been there all over. So even any information on social media has to be treated with abundant and extreme caution, has to be vetted with evidence-based medical practice, ideally with a practitioner, before you can actually subscribe to what they say.
Sir, coming back to GI and HPV surgeries, they usually involve very high risk and many moving parts. So from your experience, what are the biggest challenges, surgeons face during such, procedure in India?
Yeah. So, if you're experienced, the biggest challenges which you face are actually before surgery. So, if you're experienced, most of the challenges actually happen before surgery because, according to me, after being in practice for more than 20 years, the most important thing which a surgeon should know, which my late father taught me, was that he should know when to operate and when not to operate. When not to operate is more important than when to operate. When to operate is what textbooks teach you, but when not to operate is what practice actually teaches you. Now, which is the patient who is likely to benefit from a surgical intervention leading to a good outcome, and which is the patient for whom you should not offer surgery because he is unlikely to, survive the procedure, is something which actually comes with experience. And that is something which we should all try to pick up. Now, what am I exactly referring to? You have patients, who might be undergoing fairly straightforward procedures, but if he's a smoker, if he's an alcoholic, if he has got a lot of comorbid conditions like diabetes, hypertension, dyslipidemia, coronary artery disease, chronic renal failure, he stands at a much higher risk of, developing complications from the surgical procedure than somebody who's otherwise a healthy, middle-aged man. Now, how to streamline? There are a lot of methods by which you can actually what can I say, filter or screen these patients. But still, till date, there is no effective means by which, you can actually say for 100% for sure that, look, this guy is going to have a 100% good surgical outcome and this guy is not. Because we still haven't reached there yet, wherein we can have models which can exactly predict with 100% accuracy that these are the patients who are likely to survive a surgical procedure without any problems. And these are because there is a lot of heterogeneity, there's a lot of variables which are involved, and that makes this whole thing complicated. Now, having said that, the patients need to be extremely aware about what are the complications which they are likely to develop before, during, and after the procedure. They also need to be told about what will be done in case if they develop complications. An informed written consent has to be obtained, ideally a video consent with involvement of the relatives, so that both the patient as well as the relatives are aware of what exactly is going to be done and what are the tangible outcomes from the proposed surgical procedure and what they can expect from the surgery. Going on into the procedure, obviously adequate preparations have to be made in terms of getting opinions from the specialists like the cardiologist and the pulmonologist, the anesthetist, and a lot of other physicians and a lot of other medical therapists, including the critical care physicians, once the patient gets shifted to the ICU, before actually the patient actually makes a shift to the ward and has a or the room and has a good outcome, and before he eventually gets discharged. So actually a long drawn out process with very well defined stages. So hand holding the patient and making sure that all the checkboxes are ticked off is extremely important.
So recovery after GI surgery, it depends on, more than the operation itself. So what steps have you taken in your practice to improve patient recovery and reduce complications?
Okay, very good question. Now, the thing is that, even when I was doing my surgical residency, GI surgical residency, one concept which was coming up in a big way was ERAS. ERAS stands for Enhanced Recovery After Surgery. So, what does ERAS stand for? ERAS stands for Enhanced Recovery After Surgery, which means that, many of the procedures which used to, be done and the patients used to stay in the hospital for maybe 2 or 3 days, if not more, the hospital stay was cut short by forming what is known as ERAS protocols. Now, ERAS protocols definitely have been helped by the technical advances in surgery, which I told you earlier, wherein from open, it moved on to laparoscopic and then to robotic and all that stuff. So all that helped to cut short the waiting time, because compared to open surgery, laparoscopic surgery and robotic surgery were associated with less postoperative complications, less ileus, less adhesions, a lot of lesser complications. So definitely those helped. Apart from that, what actually helped was that in addition to this, a lot of ERAS protocols were developed. Now, what were those ERAS protocols? Previously, when I was doing my residency, all the patients used to have a Riles tube or a nasogastric tube inserted before surgery, and then that used to be continued, at least for 12 hours, if not for 24 hours after surgery. But then all those were weaned off. And then what happened was that we discarded those sort of procedures. Point number one. Many patients initially used to be routinely catheterized. We stopped doing that. Third, a lot of anesthetic drugs were employed, and they developed, patients were then later on subjected to newer anesthetic drugs, which had shorter duration of action and a quicker recovery time. So those helped. Four, pain relief. Previously, patients used to have severe pains. One of the main fears which patients always used to have was, doctor, will I have pain? How severe will be the pain? It could be even a simple procedure like a hemorrhoidectomy, but then patients used to fear surgery because the pain used to be unbearable, so-called literally, pain in the ass, as you call it. But then what happened was that a lot of newer drugs came up, newer anesthetic techniques were employed, which actually made sure that patients' pain relief was excellent. So a lot of drug delivery systems, pain patches, preemptive analgesia, which means that even before the patient perceives pain, you give drugs so that when he wakes up, he doesn't have pain at all. So many newer modalities actually came up, such that, the whole patient experience, for as far as surgery was concerned, became a very smooth process. So this has been the most important or significant advancement. So, patients after a laparoscopic cholecystectomy, they can be discharged the same day. The same holds true for appendicectomy, hernias, hydrogels, hemorrhoids, fistula in ano. All these procedures, the patients can be discharged on the very same day. So these are all known as daycare procedures. Now, there used to be some issues because the insurance companies would not give coverage if it was being performed as a daycare procedure. But then what happened later on was that the insurance companies also understood that they stand to benefit if the patient stays for a lesser time in the hospital, because they have to pay less. Whereas otherwise, if they, insist that patient has to stay in the hospital for 24 or 48 hours, they have to actually pay more. So that happened at that end as well. They also realized that, it makes sense if the patient is sent home early. So all these actually contributed in a big way to making sure that, surgery becomes safer, easier, and approachable for patients.
Sir, you regularly work with advanced and complex surgical techniques. So, how do you stay updated and bring new ideas into your practice while keeping patient safety in mind?
Yeah, so actually, it's a big challenge because the practice actually leaves you with very little time at the end of the day to keep you abreast. But then nowadays, what has happened is we have had this internet revolution. From 5G, we are actually leapfrogging onto 6G. Now, high-speed internet has made sure that you can download data in a fraction of a nanosecond, and even when you're constantly on the move, you can actually read summaries of journals, clippings, recent advances and whatnot. So all those help you to keep abreast. Second is continuing medical education seminars, or the CME seminars, which keep on happening regularly in different parts of the country, which you can, if you are unable to travel, you can even attend it online. During the COVID pandemic, for 4 years, most of the physicians used to attend these sort of webinars online from the comfort of their home. Then only people realize that even if you don't travel, you can still keep yourself abreast of all these things. Then comes the journals, which, have become or rather gone slightly out of vogue because of the availability of digital data, because nobody actually reads too much of printed data these days, except for the newspapers, which you would still love to have with a cup of coffee in your hand. But other than that, most of the journals, everything is available online. And so, you read that. So, by means of all these things, webinars and podcasts like what you're doing, people are able to keep abreast, and that's how it happens.
So when we talk about India, like there are many patients who still struggle to access a specialist GI or HPV care. In your experience, what are the biggest barriers like, and what can be done to improve access?
So, the biggest barrier to approaching healthcare is that, what I would say is, a lot of India, 70%, or what our forefathers or the politicians of the year of those days used to tell us, that 70% of India still lies in the villages. We are fortunate to be, connected on a podcast, talking over high-speed internet. You're in Hyderabad, I'm in Kerala, and then, we are able to. But how many people are able to do that? Many people in India still don't have access to toilet, except for the fact that, thanks to the recent government focusing on Swachh Bharat Abhiyan, people started getting access to toilets. People started, there were a lot of children who still had to walk 10 to 12 kilometers every day just to go to school. Potable water, drinking water, life was a struggle. Children used to be pushed into labor because their parents would want them to earn money instead of focusing on the studies. When we still are struggling to achieve these sort of basic measures which we need to afford to our population, don't you think that healthcare comes after that? So I would say that, access to healthcare comes. Definitely, it's very important. Now, healthcare cannot wait. Definitely, it cannot wait for, all the villages to be electrified. It cannot wait for all the villages to have, piped water supply. I'm not saying that. But what I'm saying is that the major hurdle still remains the fact that, we have not been able to afford what is a given, or what is taken for granted in a metro city, is still not available to our brothers and sisters who are living in the villages. Now, till that happens, how will a doctor who has graduated from any medical school for that matter confidently go and set up practice in those villages? You tell me. How will a doctor ensure that he has got the adequate medicines to give those? Because medicine is practice of medicine is just that, it's not enough that you have a doctor. You need to have medicines also. Then you need to have a nurse. You need to have healthcare facilities. Now, all those will come only when you establish what I told you earlier. If you ask a doctor who has graduated after 5.5 years of medical education to go to a village, where there is no electricity, do you think that, he would be able to do that? So the major barrier, I would say, is lack of adequate basic facilities in our villages. The moment we ensure that, definitely this sort of migration from the villages to the towns and towns to the cities will definitely stop. Point number one. Because it's the same phenomenon which you are seeing on a global level. People are moving from India to abroad. Why were they going abroad? Because they felt that, even for those living in the cities, they felt that, the affluence was not enough. They wanted the comforts of a city like London, as opposed to, what metro city in India had to offer. So if that onward migration from villages to towns, towns to cities, cities to abroad has to stop, then, the same standard of education and the other basic facilities and the basic comforts has to percolate down to the last mile. And that's what a lot of steps have been taken in this regard by the government. And I'm sure and I'm hopeful that, it's very difficult to pinpoint a time frame, but then, it will definitely happen.
So tracking outcomes is very important for continuous improvement. What are the key indicators that you personally monitor to understand the quality of your surgical results?
So, see, very important question you're asking. Actually, questions which actually provoke too much of my thought. But it's very good, because it gives the audience an insight into what actually goes in the mind of a surgeon. Now, how do you actually track outcomes? It is always best that you always compare yourself with your last case. Point number one. Point number two, every surgeon, it is said that he keeps with him a small diary which he carries with him to his grave. In that diary, he actually lists the names of those patients whom he could not save, for which he still says a prayer in silence. He still maintains a record of those patients in that diary, wherein he always felt as to how he could have done better. he still maintains a diary wherein whenever he's faced with a complication which he has not encountered, he always rings up his colleagues, takes their opinion, benchmarks himself with his peers, and then tries to achieve the best possible outcome for his patient. Now, every surgeon does that. It's just that, you don't see them doing that, but then this is what every surgeon does. So benchmarking is very important. How do you measure tangible outcomes? If you have been able to refine your surgical techniques in such a way that one, your operating time has reduced, your surgical results still remain exceptional, you're able to discharge your patient in the least possible time of, or rather, hospital stay. Four, your patient satisfaction is paramount and it's right there at the top. Five, your post-operative complication rates are very less and are on par with what is the national or the global standard for that matter. And, you have been refining your techniques and keeping yourself abreast of what is happening elsewhere, and you're able to offer that sort of surgical care to your patients. I would say that is the best way by which you can actually assess your outcomes.
This is very insightful, sir. And with the new technologies like robotics and AI slowly entering into the surgical practice, how do you see the future of GI and HPV, surgery changing in the next few years?
It's actually mind-boggling, the way robos have actually flooded the market. Even in Kerala, there are more than, say, 30, 40 centers, who are actually having robos. And you're going to have a whole swath of surgeons who are going to be trained in robotic surgery. And once that happens, once the government also pitches in, along with public-private partnership, if we are able to establish these sort of telemedicine facilities in villages where, at least, you have at least one center wherein, you have high speed internet, experts who are sitting in any city or any metro city for that matter, in Hyderabad or anywhere, can interact with the patient in, Warangal or, Nidadole or Penumoli or any place for that matter, in remote Andhra for that matter, or Rayalaseema in some district, Ongole. And then he could offer his expertise. Even surgeons could actually get trained for that matter, because many of the procedures ultimately, if you watch it once and or twice, and then you get guidance or mentoring online, you should be able to perform it. Now, if that happens, the sky is the limit. All those difficulties which I mentioned, all those can be bridged in a fraction of a second. So I see a booming healthcare sector. I see a lot of robos flooding the market. I see a lot of surgeons who are actually trained in the robo how to perform surgeries. I see a lot of these sort of facilities percolating down to the last mile, not immediately, but maybe 5 to 10 years down the lane, leading to a total upliftment in the standard of healthcare which India is able to offer. But with the caveat that this should also happen not at the expense of quality, number one. Two, it should not happen at the expense of post-operative care. The complication rates should still remain on the lower side. Infection rates have to be kept under control, because unfortunately India has got a slightly bad name in the international fora for all these things, because people used to spread a bad name about India, saying that, oh, you go to and get a knee replacement done. Infection rates are pretty high in India. So we have to make sure that, we don't shortchange on all those things, all those parameters, but ensure that healthcare is delivered to the villages as well.
And at last, at the end of the podcast, sir, for all the young surgeons who want to enter into gastrointestinal or HPV surgery, what guidance would you offer based on your own journey? Thank you so much, sir. Thank you so much. It was an extreme pleasure, talking to you. Thank you so much, sir. And the next time you are in Bangalore or Hyderabad, would love to have a cup of coffee with you. Thank you so much, sir. Thank